Hello everyone, my name is Bach, first year PhD student at Paris University, France. I'd like to present you today my study on population pharmacokinetics of intravenous and oral Ganciclovir in children to optimize dosing regimens for CMV infection prevention and treatment. As mentioned before, Ganciclovir is an anti-CMV molecule administered especially in immunocompromised patients. The concentration-effect relationship in adults has been shown in the literature. However, in children, this issue has not been studied that clearly. Few data have demonstrated not only high inter-individual variability in pediatric population, but also an important risk of underdosing, which explains why this study was conducted. Firstly, to describe the Ganciclovir PK in children preventively or curatively treated for CMV infection. Secondly, to identify the covariates that may explain the aforementioned inter-individual variability. And finally, to evaluate different dosing regimens and determine an optimal dosing schema in this population. A total of 105 children from Negahon-Malade, Paris were included in our prospective open study following these inclusion criteria: age up to 18 years old, receiving Ganciclovir in IV and oral form for CMV infection prevention or treatment. All blood samplings were collected for routine TDM and the following information was obtained: gender, age, body weight, height, and serum creatinine. Data analysis was performed using nonlinear mixed effect modeling method with monoliths and non-mem. Among these children, 80 were receiving IV Ganciclovir, 19 with oral doses, and 6 with both forms. PK data were best described by a two-compartment model with first-order absorption and elimination, which also included the effect of body weight, estimated glomerular filtration rate (eGFR), and critical illness on Ganciclovir elimination. Simulations suggested that current dosing regimens might be adequate for CMV prevention, but higher doses should be necessary for curative treatment, which mean 40 mg per kilogram per day PO or 15 to 20 mg per kilogram per day IV in normal renal function children, and 56 mg per kilogram per day PO or 20 to 25 mg per kilogram per day IV in children with augmented renal function. These findings should be confirmed prospectively and fitted individually with TDM. Thank you for your attention.